I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and welcome back to another GI Common Concerns. I had the recent privilege to work with one of my former mentors, Dr. Alvin Zafas at Virginia Commonwealth University, and we sat on the stage and just talked about GI pearls, things that we've learned over time, things that you learn from books or perhaps from experience or lectures. And I wanted to put these in perspective for you and share with you these discussions over the next couple of iterations of this section. We're going to talk briefly on esophageal pearls to start, and we'll talk first on esophageal dysphagia. Dr. Boyce, one of the godfathers of the esophagus, taught me to take a good history on esophageal dysphagia. We're talking about solids now. And when you ask, do you have trouble swallowing solids, very frequently they'll say no, but then you have to ask. Bread or meat is very common and easy maybe to elicit. But you'll find that there are other agents, in particular doughy bread or pasta. Sometimes these will glom up and make a more or less a dough ball, if you will. And when you ask about these, they say, yeah, no, I do have trouble with that. You find that things like bread, patients may start to toast their bread because they realize that the doughy bread, not quite so simple. These make the transits. We'll talk about regard to things with skins on it as well, and ask them about things like apples or fruits or vegetables, potatoes. Those things that have skins don't transit quite as well. Anything that has a luminal size of 13 millimeters or less typifies what causes dysphagia, which is why radiologists do a 13 millimeter barium tablet when you ask them to do a structural evaluation with barium, and you should ask them to do a tablet evaluation. And that's something that you then would also incorporate these food groups to tell them to avoid till they come in to get their esophageal dilation. One about oropharyngeal dysphagia, don't forget a chin tuck or a chin turn like this may be helpful. It slows the transit to the posterior pharynx, and again, helpful in this particular situation. When patients have a nasopharyngeal type of regurgitation, when they swallow, this should alert you to a neurologic cause as it relates to dysphagia. I've actually picked up a case of myasthenia. When somebody came in, they said, when I swallow, stuff comes back up through my nose. It sounds horrible, but you need to be thinking about neurogenic causes at that point. Esophageal dilation, a couple points. One is, don't forget to deflate. We get into through the scope dilation, we start dilating, and then we progressively dilate. Deflate between dilations, reinspect the mucosa, and then reinflate depending on mucosal disruption. What happens if you continue to dilate without deflation? You may be infusing more air. If you do that, you get gastric distension. The patient may belch, and that against a closed balloon in the distal esophagus may create barotrauma, and you may see this if you haven't seen it already. And again, deflate, inspect, reinflate. Kenalog injection I found to be quite helpful in these patients that have anastomotic strictures or even strictures related to caustic congestion or radiation. What I do is when I do my dilation, the first area that the mucosa is disrupted, again, deflating between dilations, I'll target that as where I target my first injections for the Kenalog. I really want to make sure that's where the triamcinolone goes. That's where this fibrosis is most intense. That's why it broke there first. And then I'll go to my quadrant injections using typically 40 milligrams through the course of the injection technique. Altoids, this is a real trick that Dr. Don Castell, one of my mentors, taught me a long time ago as well. Warm water and Altoids when you have the esophageal spasm. When I dilate esophageal eosinophilic esophagitis, I always warn my patients, again, you may have a little bit of mild chest pain, and this is something that I tell them routinely, have some peppermint tablets. The Altoids are quicker because they dissolve quicker. A little bit of warm water and may assuage that. The peppermint tends to be a smooth muscle relaxant, may be quite helpful for them to have after these dilation attempts. Narrowband imaging, we use it for the patients with Barrett's esophagus. If you have not seen what EOE looks like, eosinophilic esophagitis, turn on your NBI. You'll see a vascular network that changes rather from normal. In the narrowband imaging, you'll see with EOE what I call a dot matrix. You lost that vascular lacy integrity, and you'll see these little dots as it relates to the esophageal, the mucosa. The same is what you'll see with lymphocytic esophagitis, and I've had a number of times where I thought it was EOE, and I did not see it on biopsy, and I called the pathologist back and said, look for lymphocytes, and lo and behold, the lymphocyte count was elevated, typically greater than 20 lymphocytes per high power field. This is lymphocytic esophagitis. Typically see it more in 50 and 60-year-old women. It has an association with Crohn's disease. Lichen planus may be related to stasis, but again, if you think it's EOE and it's not, ask your pathologist to look for lymphocytes. Retroflexing in the nasopharynx is quite easy. I find it quite helpful when I do an evaluation sometimes for GI bleed that I don't find a GI source. I'll come back and I'll retroflex. So just before you get to the uvula, distal to the uvula, I'll gently pull down on the inner knob, and then I'll gently pull to the left with my right hand. I'm right-handed, and that should put me over into the area where you can look right up into the nasopharynx. You'll see the turbinate, you'll see the eustachian tubes bilaterally, and you can look up into the turbinates. You can find if there is a nasopharyngeal source of bleeding. I'll also look at the turbinates if I'm thinking about LPR and I'm looking at an allergic component, atopic things, septal deviation. You'll see, just be aware that's very easy to do and should not cause any trauma. Rumination and singultus, don't forget diaphragmatic breathing. We've talked about this before, and I'll give you the link back to that. If you've not learned this technique, very easy to do. Teach the patients, and I found it very rewarding, particularly in singultus and rumination. It's really the standard approach to do this. Again, worthwhile learning. You're not taught this in lectures or class. Laryngopharyngeal reflux, we see a ton of patients with LPR, rule out GERD. They're kind of a heat-seeking missile. They come in, we may even study them, they're not refluxing. But I then say, what else could it be? And I'll take a voice history. I'll ask about fatigability of the voice, hoarseness, and I'll look for signs of habituation, repetitive throat clearing. When they come in, they're talking to you and they're going, these are things that we need to break. We can't just send them back to the ENT or whoever sent the patients to you, rule out GERD, without a better direction. So I'll talk to my patients about habituation. My tricks are I'll have them swallow, keep a bottle of water with them constantly, water, rather than try and clear things or cough things up. I will have them try some water, and I'll have them use a lozenge very frequently through the course of the day. I like the menthol lozenges. It helps a little bit of the nasopharyngeal clearance, and again keeps them swallowing. The liquids help the viscosity being low as it relates to the sticky secretions they get in the posterior pharynx, and again decreases some of this urge to have habituation. They may even need a voice specialist. I have voice specialists specifically in physical therapy that works and has the interest in voice. It's not just a general physical therapist. They really have to be focused on voice when you make these referrals. Since I mentioned the LPR, don't forget too, some of these patients do get into this neurogenic component of a cough or a repetitive clearing. I find it more for cough, and this is something that we see in rule out GERD. It's not GERD anymore, but I find that to break that, they need something that changes the neurogenic component of that. I've used tramadol very successfully, low dose at bedtime, starting at really a very low dose HS, and then go to a BID dose. This is something that I found inordinately helpful for a month, maybe two, and then they start to decelerate and get them off this over the course of the next month or two. Some of my laryngeal experts have also used amitriptyline. I found tramadol to be the most helpful. So GI pearls, things that you probably haven't learned and you haven't heard of and may certainly not have seen in books, but I wanted to share some of these with you and hope they're helpful for you in carrying you better into the approach to the esophagus. And we'll come back in future discussions and talk about some of the other GI organ systems. I'm Dr. David Johnson. Thanks again for listening.